noticed that when you spoke with this man, you weren't trying to go after facts. Some interviewers might, to establish time sequences or to get some idea of what his circumstances were, but you seem to rather exclusively give him an opportunity to tell you his story.
That's right. As you well know so well, the traditional way in which that has been done has been by using free associative method, and indeed that's a very powerful tool for that, to that end. However, in an initial interview like this one, or a consultation interview, and with many, many patients, such a free associative technique is obviously impossible, or at least has only a limited place, even though it's a very important place. So one has to begin to try to think about ways in which the material can be elicited spontaneously, and that means immediately that there's certain very strong reservations have to be entered about questions, because they have a very valuable place and can constitute the cornerstone of the traditional psychological examination. They nevertheless are so enforcing and demanding as to distort the material that you seek to elicit spontaneously.
In this particular patient, I assume that you were alerted very early in your contact with him by his key words like great expectation, obtainable, expectations from others as well as for himself, and the painfulness that surrounded it. It was almost as if he said, look, I've got a inflammation, and I assume that was a real clue for you to back off. On the other hand, I imagine with most patients you would start off hovering a little in the background, or not coming forth.
Again, again, another principle for me is the business of finding the other person is the first order of business in mind. That is, until we have some sense of what the spontaneously emerging person is like, we're only going to collect what Aristotle called wonderful works of clinical fiction. It's going to be something that's a performance that's put on for us. The earliest clinical decision I try to make is whether someone is coming toward me or moving away, whether someone is advancing on me, whether the psychological material is approaching me and is going to be distorting me, or whether they're leaving the room, say they're going crazy, or they're just indifferent, or they're only interested in themselves, or something which removes them. And if they're leaving, I have to move toward them. If they're advancing on me, I have to do something to get them away from me so we have a reasonable working distance. I didn't think this was a particular problem with this young man, who's, on the whole, relatively well put together and has a sort of measured, somewhat intellectual style, and is not going to be invasive of me, nor is he altogether indifferent to me. He's easily enough brought into some kind of a working relationship. So that wasn't a great problem. But at the same time, one wants what occurs to bear some of the marks of a more permanent nature of what he's like. And so, as you say, this your word is a good one. There's a certain amount of hovering that goes on. I think the word that Freud used was sort of free-floating attention, something of that kind, in which an atmosphere of revelation might occur. Furthermore, another reason I don't go after so-called facts, although I must say that people mean always by that, but by facts. But the reason I don't is that I don't want to find out too much too soon, because I won't know what it means, and it might be shocking to me, and he might be ashamed of having revealed it. In the sense, I want to control, to some extent, the pace of his emergence, so that he's not too exposed, he's not too stripped bare. And that brings me to a third principle, which is that the purpose of the first interview is to make sure you have a second interview. The general working rule, that's sound, and if not the first interview for you, at least the first interview for somebody else, so that the patient goes away feeling this is an experience they wouldn't mind repeating. That seems to me the main burden of the first interview, except in emergency situations. And it's, in my experience, too much neglected.
I noticed there were a number of tentative touches or gentle touches in your interview. There were a number of things which are somewhat non-specific in your style. You tended to make the psychiatric noises that are kind of non-specific to let him know you're still alive, breathing and interesting. In other words, you didn't intrude on his space very aggressively.
I mean, the first part of the interview was ostensibly about his experience at college and how he had taken a nosedive after coming rather complacently into this obviously much more competitive environment where he wasn't as much honored, perhaps coddled as he'd been before. And that had left him self-critical and with great expectations, more or less an inferior person, and that he's still trying more or less, and I think successfully, to recover from this nosedive he took and assess what he calls his internal damage. Interesting expression. That attracted me more than any other expression he used.
It was the only one of his that you repeated.
Was it?
I think so. You said what you called your internal damage, and you gave him room to say, well, it didn't mean anything, doctor.
Well, one of the reasons I didn't pursue it further was that I thought it was the closest he got to the moaning and groaning that he says he usually doesn't do. And so I didn't know whether there really was very much internal damage, but I have the inkling that he thinks there's been a great deal of internal damage. And furthermore, I would bet that he doesn't think anybody has yet appreciated how much he's suffered. And the reason I didn't indicate that I might appreciate it, first of all, I don't think I do appreciate it, but also, I'm not sure it's necessarily a good idea, because there's a little bit of a poor little boy in here that if one paid too much attention to or coddled, you would really be giving him very false signals and would send him back to the point where he was a dear, sweet, little, wonderful, promising prodigy, and where everybody was supposed to clap and scream with delight when he more or less got the milk into his mouth. But that was as close as he came, I thought, to making a sort of suicidal gesture in the interview, so to speak, telling me how bad it all was.
Yes, that's an interesting word, a suicidal gesture in the interview. There was something very interesting that you wrote that was published a few months ago. You said that psychiatrists today now have to realize that patients aren't necessarily patients yet. And you didn't say, now look, let's get something straight, I'm the doctor and you're the patient. You never said anything like that.
That's right. I wouldn't, because how much of a doctor am I? 80%, 90%, 100%? How much of a patient is he? Well, he's obviously something of a patient, right? But to try to enforce that kind of role on him would be dehumanizing. It would also do something medically bad. It might claim that he was sick when perhaps he's not, or that he's only limitedly sick. I think that gets most clearly in mind when one sees families where the sick partner is not the sick partner, it's somebody else. I start out by questioning the traditional assumption that the patient was in the room. I say the patient has to be found. Now I'm questioning the assumption that it's necessarily a patient who's in the room. Right, exactly.
There's a great deal to suggest that your hesitancy and your scientific skepticism is true. The patient didn't tell you that these expectations are not just his own, that in fact these expectations have been held out periodically. And when you said, is there any inkling that these expectations came from the past or from other relationships, he immediately said that he wasn't interested in talking about that. So,
well, if there's a difference between the way I conducted this interview and the way I might work under other circumstances, it's that I avoided here any specific discussion of his family. I gave him opportunities, but I really didn't. In most other circumstances, I would certainly have made what I call projective statements about his family members, and things about, well, I guess mother really thought she had to have the best kid in the world. Something like that I might have thrown in, but I didn't do that because of the confidentiality thing in this interview. And I thought that it's possible that both he and I, you warned him about that, using names, but also people. And so I kept that a little anonymous for that reason, that I didn't think it was fair to him to expect him to do that under those circumstances. And I don't think it matters very much in the interview, but I think that's a difference between what I would do under other circumstances and this one. As I said, I wouldn't ask about his father and mother. I regard most questions about parents as absolutely unanswerable. Tell me about your mother. First of all, that's a demand, which I don't like to make on people until I know them pretty well. But also, what the hell are you supposed to tell them about it? There's no way to go. So I use, as I say, what I call more often projective statements in which I'll put down a particular feature about the parent and see if I get a plus or a minus on it. Those interview tactics seem to me genuinely respondable to. If I say, well, mother's about 5'6", but she weighs 325 pounds, you know, I can get out of that somewhat counter what she looks like, which is probably fairly reliable. Well, if I say, you know, what's your mother like? I don't know how one answers it.
Clinically, that when you ask a sicker patient what their parents are like or what their mother's like, you very typically get the same answer. They're normal, doctor.
Yeah. Right.
And that's a favorite response from, it's in my experience, from schizophrenic people.
In fact, I agree 100% with that. Really first-class kooky, and they're called just great.
But let's get back to his patienthood, because that's so crucial, it's fundamental. And basically you said, I'm certainly available, but your problem is that people have had great expectations and demands on you, and they've sent you to a psychiatrist, and you're here. If I were those other people, I would want the psychiatrist to say, yes, indeed, there's something wrong with you. You didn't fulfill those expectations.
Straightened out now.
And in fact, that is exactly what you avoided.
Well, that, for two or three reasons. One reason we've already discussed it. One doesn't want to join them in this. I mean, they may be estimable people, but I think it would be advisable to have a position somewhat different from theirs, and therefore not to be identified too closely with them. And second of all, one doesn't want to make the assumption that anything about this person that corresponds to that account of a damaged person should be repaired by me. And thirdly, that is that, in fact, we're not going to be able to find out much about him or about them on which anybody would agree. And that's the state of psychiatry. We'll have 4 or 5 very different accounts of the nature of the pathology, the source of trouble, whether it's biological, social, intrapsychic. We'll have a whole mess out of it, which means that if I am to announce that I know what's the matter with him, I'm taking what I think is an indefensibly unscientific, totally sectarian position. That doesn't bother me a bit. I'm rather glad that the work then shifts from a basis of knowing to one of searching. And in the course of that, he will have many opportunities to decide which of these factors are more important to him, which kind of problems he should work on, whether he selects the wrong friends, or whether he gums up the relationships with them, or whatever kind of mechanism is at work. And I will be there, hopefully, as an ally or something of a companion, maybe occasionally a guide in sorting out what the sources of the difficulties are. Another principle dear to my heart, and that is that the work has to be shifted from what it's so traditionally been, a sort of didactic, knowing, instructing. I know reality, and I show you, Mr. and Mrs. Patient, what the nature of reality is and how you're out of sync with it. That's been the more traditional position, and I think it's quite wrong. First of all, we don't know what reality is, and second of all, of course, we don't agree about what the mechanisms of distortion are.
About 2/3 or 3/4 of the way through the interview, it was very clear, and you had some ideas of your own. You were very careful not to impose them on the patient. You said, are you justified in accusing yourself of searching or pursuing both fame and now love? And is that fair? In other words, are you unnecessarily greedy, or and how do you feel about it? It was a highly integrated response on your part, but still one that didn't say, I wonder how abnormal your narcissistic impulses are.
That's exactly what I'm talking about. Abnormal narcissistic impulses. I've got to avoid talking about it in such a way that I take a position on the side, say, of a punitive superego. And that maybe this whole charge is false against himself. I don't know. But anyway, he made it. And so I can repeat it safely in that context without reinforcing the very thing I may be trying to correct. I mean, maybe he has a punitive superego. Maybe it's a primitive narcissistic remnant. But if I then line up with it against his aspirations or something, then however accurate I might be in diagnosing, I might be doing the reverse of freeing him up a little bit from its clutches.
Since you exercise this kind of scrupulousness, how often would patients claim Well, Dr. Havens, you are so insistent. You expect this, you expect that. I imagine no matter how careful you are, you're bound to get a certain amount of transference of the primitive superego.
Sure. Well, that's inevitable, and even here there was a hint of it, I thought, in that damage remark. You should know how bad off I am, and you should do something about it. That was as close as at least as I could recognize of just a fragment of what you would call a psychotic transference. And that certainly is a very common thing in neurotic and or even normal people. But what one does about it? Well, in the presence of insistence of what one feels, it is not an insistence that one can respond to in a matter-of-fact way. Then one has to find a position in which one disengages oneself. Now, there have been, in my understanding of the development of my field, there have been 3 ways by which people have disengaged themselves. One is not to engage yourself. That, you avoid the transference by avoiding the patient or diminishing your relationship with the patient.
You see them less often, you keep a distance.
You avoid the genetic, historical, personal contact, really. It's very businesslike.
You can't avoid the unavoidable, though.
Right. Although some people are pretty good at indicating, not letting anything light on them, and their indifference is massive enough to discourage that. But I agree with you, I don't think it's avoidable that way either. The other way is, instead of reducing interpretations, you redouble them by means of an enormous verbal dexterity, interpreting these things. And with some people, that is a successful maneuver. But I think that is beyond most of us, and I've suggested what I call projective and counter-projective speech as a way of dealing with that problem. And for example, if I wanted to deal with the damage, I did a little tiny bit. When he says to me, there's this inner damage, I'll say something like, that doesn't sound so good. In other words, I'll take his account of it and heighten it, maybe even caricature a little, and I'm essentially putting him out there. And you'll see it comes up with hospitalized people very often when they'll drop into the conversation that they're schizophrenic. They'll say that. And now you're obviously in a box at that point. You're going to be quiet and agree with it? Are you going to say, gee, that's too bad? What are you going to do about it? It puts you very much on the spot, and it says, I'm a helpless, crippled person, and therefore, how can you sit there? So you can't sit there. So I would say something like, well, let's hope you're not completely schizophrenic, something which brings the whole problem forward, and makes the person begin to question it. So instead of thinking about it as a sort of fixed phenomenon relationship between us, we're looking at it out there. That's what I call projective speech. And in that way, in my experience, very sticky expectations can be taken off the therapist and looked at productively. That was the way Harry Stack Sullivan made his reputation, by straightening out people's transference psychoses.
I was going to ask you about Harry Stack Sullivan. Was this room set up in such a way so you could talk to the patient in the most projective way? Were you comfortable with your facing the patient?
Well, this was not a man who was doing a great deal to me of a transference psychosis. So this is a...
How would you change the seating arrangement to facilitate talking with him instead of against him?
Right. Well, as you know, one of the suggestions that Sullivan made was that you essentially point outward rather than at each other.
Right.
And that way provides an outer screen.
Yes.
Instead of the screen on the therapist, the screen is outer, and because projection does to some extent follow attention, you're already beside the person rather than against them. Yeah. Well, that's an advantage with anybody who's againstness. It's going to be either very, very loving or very, very hating.
How about your own feelings? Was there anything that was particularly difficult in this interview?
The main burden was the one of performance.
Yes.
And in the beginning of the interview, I tried to turn that to our advantage by stating the theme of performance that he and I shared, that we were both on stage. And you remember at the start of it, he said, well, you're really more on the spot than I am. And I thought that was very nice, and it gave me a very good feeling about the extent to which he's with it. I mean, he's with
Yes,
it.
yes. And he reassured you about the fact that he's a child of the electronic era and that he's not so uncomfortable.
He was not so uncomfortable, and he could even sort of help me if I got lost. So that he took an empathic attitude toward the interview very early on, even if it was a little lordly, which he is, his beautiful beard and curling back hairs and everything. But he exercised his lordliness in a nice way that made me comfortable, and that in turn could lead into the problem of his life performance and what he'll do in the future and his disappointment himself now and how he was brought up to be a little bit prodigious. So that made me feel better, more comfortable. At the same time, in an ongoing therapeutic relationship, it is something that would have to concern me a great deal. It's one of the reasons that the simple announcement that I'm the doctor and he's the patient, one of the reasons that that's out to lunch is that in many therapeutic relationships, the real person taking care of the thing is the patient. Many even schizophrenic people, particularly some schizophrenic people, have all their lives been parenting their own parents anyway, and it's no big step to begin parenting you. And with sensitive and aristocratic-minded kinds of people, especially if they like you, the whole work can go forward as an effort to do something for you rather than for them. And that is such a seductive and wonderful pose. We can fall victim to that easily. I think if I had any criticism of my performance, it would be that I was not attentive enough to that due to my own anxiety and uncertainty, and that I might have reinforced a little more than I would like to.
He's looking after you.
In his being the superior person who can come into the fancy competitive college and be taken good care of, only to find that he's flat on his ass. And I think if I had to do it over again, now that thinking about it in our conversation, that I would have brought forward such ideas as not only was he had great expectations, but perhaps there was even a touch of royalty in that. Superiority, and even royalty, even some sense of noblesse oblige. I know when I went toward the end, I said something about how he probably learned a great deal out of these years. And I prefaced it by saying that I know that's going to sound awfully condescending and patronizing. It may have been that I was, sharing a quality we both have, which is to be patronizing, and that may have been one of the jointures of the whole experience.
I'm not sure that's very fair to yourself or to the patient. It's really the essence of the enterprise, as you say, to be fair and fair to everyone, and that's an impossible task. But there was a little bit that quality of privilege that went through the interview and the exchange, and it probably didn't get attended to. But in fact, I think it did in this sense. Let me ask you about it. He used a number of metaphors in the interview. One was the metaphor of the tree that falls in the forest.
It's wonderful, wasn't it?
Yes, and I think he was in some ways telling you that since you're really not there, you haven't found me yet, don't think you know what I said. And I think he was warning you. And then there came another metaphor, the metaphor of the wound-up watch that sometimes doesn't run down evenly, but sort of just explodes and unwinds rather impulsively. You identified that and used it a few minutes later. You mean occasionally somebody needs a kick in the ass as well, which, in a sense, attacked the lordliness and the royalty and the noblesse oblige quite directly. Were you aware you were going to do that, or is that just intuition?
But no, I thought things were getting a little fancy, wordy, and talky. And we were, like we were at a very fine club together, talking about somebody else. No, I also love that expression. Because he is a tree. He was a mighty tree that went off to the woods and was going to be the greatest tree in the woods. And
he was a very big forest, though.
Except that he was a tree and he was in the forest, and boy, did he fall down.
Yeah.
And then sustained this damage, and isn't sure he's really going to get up again, or if he does get up, whether it'll be a bush or something. Yeah. And the companions, and there were those who wanted to hold him.
He didn't want to.
He didn't want to hold him, and furthermore, some of them didn't know because of his apparent self-sufficiency that he might need to be held. And he came close to criticizing the world at that point in terms of they're really not holding on long enough. And if they didn't hold on long enough, then he was alone in the forest. And so he took his fall. I don't think he's suicidal now. I think he's gotten through that. he hasn't quite extracted enough repayment from the world. And I'm sure that whoever is his therapist will find that out.
And then the second theme, the habit of ignoring the discomfort like an ulcer. And then he would take the aspirin to get rid of the ulcer pain. And that would exacerbate the ulcer. And so here he was warning us again that the treatment might exacerbate the symptoms or the disease, even though you thought it was putting balm on it because it was an analgesic. And here again, you were sort of stuck with the problem. You said, I hope what you say is not only just autobiographical. And that was a nice way of saying, I see there's a problem here. Are you saying it's your own? And stopping. It did give him freedom. It gave you freedom. I thought that was a very important demurring of responsibility that was very appropriate.
Well, I think that puts, at least one of my perceptions of him, that he does need to be held, but he has to be held in a way that is right for him, which is pretty tough to do. He is making cries for help, but they have to be answered in a form that is very special, or he will not, or they'll make his ulcer worse, etc. I think there's a kind of exquisite feeling about him.
I think you did get to that when you mentioned kicking the ass, because that kind of brought things down to earth.
He didn't mind that either. He repeated
No, he
that.
liked it. But earlier, when you asked him about the people in his life, the companionability, he did not respond. You learned so much on the basis of exquisite attention to what he said. On the other hand, if you were going to write a case report and had to present it to your supervisor,
you might be in trouble. Well, I tell the residents that when they present their cases under these extraordinary instructional demands that we've all imposed on our students, that they invent as much as necessary. I mean that.
Are you serious?
I'm serious.
All right.
I think the idea that you're supposed to go in with the patient and bring back all this information like you were on rounds at the Mass General or something is profoundly assaultive on the patient. I grant there are emergency situations where it may be necessary. So I say either invent it or make it up, or if these demands are made on you. I like to compare most of our clinical work to a surgeon who would sort of, patient comes into his office and he throws the patient down on the table and begins to operate. I think that's really the nature of too much of our work, I feel. And surgery is a good analogy. It was a good analogy for Freud, it's a good analogy for this. And it takes an enormous amount of preparation. So I don't want to know very much very soon.
Well, Freud used the surgery analogy in many different ways. One was that you can't practice psychoanalysis like the Turkish gynecologist, that is, by examining the patient's arm through a curtain, that you basically have to see what's going on. Then he used the surgeon analogy in a somewhat different way when he talked about having to have cool blood in the situation, objectivity. And so he's used that many times. Also, he used the surgeon analogy as taking seriously that psychotherapy is an operation. That it exposes, that it has its dangers.
And it's transference, right? Yeah. It gets out between us and we can work on it. And to me, that's an immensely powerful idea. The next thing he did with that, again, turns around this whole business of the language of the work, is that I think he had the idea that there was sort of an exact way to talk that would fit the patient's needs, and that the exact interpretation would somehow settle the problem out.
You're talking about Freud now.
Freud. I don't think the mind works that way. I don't think it's at all that there's a sort of a slot statement that you fit into the mind that then readjusts the thing. I don't see any reason to think that. And the idea of exactness is not so useful as the idea of, say, harmony or counterpoint, or something that seems to me more correspond with the two mental things coming together. But surgery as a procedure in which one prepares and then does something to what one has prepared as a crude analogy that's valuable. The other point is what you say to your supervisors, which then distorts the whole process as a result. I never tire of quoting Freud's on on how the cases that go best are those which are never discussed. No notes are taken. The therapist keeps a very open mind, so that the whole thing goes forward in a completely different fashion than our supervisory analytic training suggests. Now, granted, Freud was wise enough to say things on the opposite sides of most questions, in the sense that way you're more likely to find at least one thing that's right.
Where do you feel the locus of treatment takes place with a patient like this? Does it take place between the two people? Does it take place in him? Does it take place between him and his world outside?
No, I think that's a good question. I don't know. It may take place in all those places.
Mm-hmm.
I'd be surprised.
That suggests a question to me that once you make a response to a patient in a certain mode, whether it's direct, whether it's existential, whether it's psychoanalytic, or whatever the mode is, you said, I would prefer not to lock myself in until I understand the patient. I want the patient to tell me more first. Now, is it possible to postpone taking a position? How long should one postpone? Is it determined by yourself or by your patient?
Well, I think do something and it generates a certain momentum. In my own practice, I have no great confidence that the position I take is the right one, and the patient is dictating it to a large measure anyway. But I use very crude tests in my own mind. I mean, I mentioned one of them earlier. That is the patient moving toward me, or is the patient moving away? Well, if they're moving away, I've got to find them, and if they're moving toward me, I've got to do something about the distortions that they're going to be introducing by their invasiveness. So that sets up a certain kind of line of work to some extent. And then there are people, and I think they're the people that have kept psychoanalysis in business and believable. If you just shut your mouth, the whole thing unfolds. If you just shut your mouth, they'll develop the transference neurosis, they'll take you into the primal, they'll go right through the whole thing. If you just shut up. And I think you can analyze them on the back of a truck, going 60 miles an hour. It does unfold. And there you shut up. And so I think that there's some kind of, I like Harry Solomon's old term, lore, L-O-R-E, about what you can do with different kinds of people. But I think it's at that level.
What, in retrospect, now that we've talked about the encounter you had this morning, what was the most difficult feature? Was it his reluctance to do anything? Was he caught in at a certain distance? I wasn't sure, in using your terms, what way he was going.
I don't think he knows. I think you're right. He's very much in a holding pattern. He's very much uncertain as to whether he really wants to venture out into life again. He's been hurt. His feelings have been very badly hurt. And he has fallen in the forest, and he has sustained internal damage. And,
he might want to sit there and make sure his leg isn't really broken.
That's right. I don't want to do anything. And I was perfectly content to sit there, and I think whoever is going to be with him is going to have to sit there for a while. And we know from our long experience in this work that you don't have to do anything right away. And so that I would, if I were going to see him regularly, I would think that was quite enough for the day, maybe more than I would like to. I like Oscar Wilde's remark about a mistress and a cigar. That one about how you should drop them both while you're still enjoying yourself. And that's the way with interview. You don't want to go on longer than
everyone, no matter what the degree of experience with patients, I think ends up like the writer with a blank piece of paper. Well, what would I write? What would I say?
Analytical habits carry us through.
And enjoying the interviewing process.
That doesn't keep a person, though, from, as you say, being nervous and blanching, and also thinking. That's what we should talk about, thinking. Because I did one piece of thinking in there.
What did you do?
And that was that you can divide life into love and work, right?
Yeah. Well, that
was my thinking.
Yeah.
So I tried not to do any thinking. that's hard work not to think in, and I was trying not to think in. Let's see what sort of developed.
Do you think that most of the time, then, what you're doing is listening?
Listening and sort of vibrating and trying to feel something, maybe wondering. I don't think it's ever been better said than in the Freudian phrase, as an evenly hovering attention, not or what I sometimes call not concluding.
Well, I'm sure this patient would come back. I think you piqued his interest.
To continue the course, please turn to audio cassette number 11, side A.